good morning everyone. Today we will continue with our journal club presentation with Dr. Tia. She will talk about the second part 2 of CT of the neck, the reporting in the emergency settings. Last week we talked about a lot of different topics about the emergencies of the neck, and this week we'll continue with our talk and we'll see what else can we learn.
Good morning everyone. Today we will continue our section about the remaining parts of the neck CT imaging, we continue with the thyroid gland.
We can't hear you. Remove the mask.
I am sick, that's why. Today we will continue with our next parts of the CT of the neck assessment. The next area which we will assess during the examination of the CT scan of the neck is the thyroid gland. Actually, we don't have many emergencies of the thyroid gland, but we can have incidental findings. And we can find underlying conditions that may have led to an airway compromise, for example, due to, for example, an enlarged thyroid gland, extensively enlarged thyroid gland, or sometimes incidentally we may find an underlying malignancy of the thyroid gland, an abscess, which is a rare condition of the thyroid. We can find an abscess in the thyroid gland, and usually the thyroid gland is normally it's hyper attenuating because of its iodine content. As we know, the CT scan is an X-ray like modality. It's using X-ray, so whenever there is an iodine in an organ, we can see it as an hyper attenuating region, and this is in the case of the thyroid gland. The thyroid gland, when it's enlarged, it may compromise or compress the trachea, and the underlying conditions of the thyroid gland also can be assessed. For example, diffuse enlargement in case of the goiter, in which the thyroid gland will be homogeneously enlarged and homogeneously enhanced when we give contrast media, and underlying nodules will appear as a hypoattenuating nodules. For example, this is a case of the Graves' disease in a 29-year-old woman. In this contrast enhanced CT image, it shows an homogeneously enlarged thyroid gland. The Graves' disease, as we know, is an autoimmune disease of the thyroid gland, and which there will be enlargement homogeneously bilaterally in the gland tissues. This is another case of the thyroid goiter, in which the thyroid gland is extensively enlarged and it's compressing the trachea. The tracheal lumen is decreased. There is an underlying hypoattenuating nodule is seen in the isthmic portion of the thyroid gland. As well, we can see calcific changes, we can see cystic changes, and these changes all are identified and diagnosed when we do a CT scan of the neck. Actually, the thyroid gland extension is usually a substernal extension, but sometimes its extension to the posterior mediastinum may occur. And when we do measurement of the retrosternal extension, we measure it from the suprasternal notch. From here downwards, how much it's extended. So we measure the extension of the thyroid gland in this way. Actually, the thyroid gland is encapsulated, so it's rarely associated with a fat stranding or associated fat stranding, unless there is, as we said, rarely underlying abscess formation that may lead to the inflammatory change surrounding the thyroid gland. Another entity in the neck, we see the other salivary glands. We have a parotid gland, we have submandibular gland, and we have the sublingual glands. These glands, except the parotid, in which it has a low fat content, the other one are mostly iso-intense to the muscle tissue, but the parotid is between the muscle and the fat. Its attenuation is between the muscle and the fat. And in case of this condition, the Sinusitis, we see it in two patients. The acute right submandibular Sinusitis in 57-year-old woman. In an axial contrast enhanced CT image, it shows an enlarged hyperattenuating right submandibular gland with internal surrounding edema and overlying thickening of the platysma muscle, because we say the platysma muscle is an important landmark, and we can see its thickening when there is underlying inflammatory process. And in comparison to the left submandibular gland, which is normal, and the axial contrast enhanced CT image obtained in a superior section. It shows a stone and in the distal portion of the dilated right submandibular duct. Actually, the causes of the Sinusitis is usually either it's infectious or due to a stone, and the stone in the submandibular gland, it's more common. Why? Because the duct of the submandibular gland is coursing upwards, and it has a small orifice, papillary orifice, and the viscosity of the saliva in the submandibular gland, it's higher. So in these conditions, they predispose to the formation of the sialoliths more in the submandibular gland rather than the parotid glands. But actually, the stones in the submandibular glands, we may not always see it because of the strict artifacts of the dental areas that will occur in the CT examinations of the neck. And in the C, the image of the C, we see a coronal contrast enhanced CT image at the level of the parotid gland in a 22-year-old woman with acute left parotiditis, shows edema, enlargement, and hyper-enhancement of the left parotid gland. Also, there is again thickening of the platysma muscle, and in comparison to the right parotid gland, which is normal, we see it is a normal gland, the other one is abnormal. And additional image in this condition, in this case, didn't show that there was an underlying stone, so it may be mostly a viral mumps or viral sinusitis. As a reminder to the lymph node stations of the neck, as we know, we can easily assess it from the submental region. This is 1A and 1B, and then anterior to the sternocleidomastoid, we come down 2, 3, and 4. And then posterior to the cleidomastoid, 5-1 and 5B, 5A and 5B. And then we have the supraclavicular and infraclavicular. We have 7 levels of the lymph node stations in the neck, which are important in assessment during the CT scan of the neck. This is again another leveling of the lymph nodes. We can see from the above the hyoid, we can see it's level 2. And the level of the cricoid, between the cricoid and the hyoid, we can see the level 3 lymph nodes. Between the cricoid and the manubrium sternum, we can see the level 4. And then we can see the level 7, which will be infraclavicular. And this one again, a coronal view of the levels of the lymph node assessment of the neck. Actually, the lymph node enlargement is an important entity in case of the CT scan of the neck. It may give us an impression of the underlying condition or underlying causes. The lymph node enlargement, for example, in cases of either if it is due to malignant cause, inflammatory cause, or any other reactionary cause. Because usually if the lymph node is enlarged homogeneously in its normal oval shaped with its preserving hilum, this is maybe a normal benign reactionary lymphadenopathy. While a metastatic lymphadenopathy in the neck, usually it's getting rounded, it's losing its ovoid shape, and it has usually a necrotic area if it is associated with a squamous cell carcinoma of the head and neck. While in cases of the lymphoma, Hodgkin's lymphoma, which is a common cause of the neck lymphadenopathy, we may not see this necrotic inside necrotic changes of the lymph node, which makes it unlikely for the lymphoma. So when we see the necrotic area, it's mostly going with the squamous cell carcinoma of the head and neck rather than going with the lymphoma. Sometimes when the lymph node capsule is eroded or ruptured, these lymph nodes will be matted together and may become like a mass and coalescent together. In these cases, it may be difficult to differentiate the malignant causes from the inflammatory causes. Sometimes even the malignant lymphadenopathy, their membrane will rupture and there will be stranding and we cannot differentiate the site. So this may occur also in malignancy. In these conditions, only the biopsy will guide us to the final diagnosis. Another condition we have mycobacterial lymphadenitis, which is called the scrofula. It's either tuberculous or non-tuberculous. And this is, as we know, for when you have a TB lymphadenopathy, for example, in acute phase there will be enlargement of the lymph node. And after that stage, there will be central necrotic area, hypoattenuating area. And this is a case which is showing a scrofula in the left side of the neck in a 43-year-old man with a contrast-enhanced CT image shows centrally hypoattenuating cystic lymph node. With a minimal surrounding fat stranding, another lymph node has been ruptured and fistulized into the skin. Actually, this is a complication of the mycobacterial lymphadenitis, in which usually it will lead to the sinus or fistula formation. It will erode the skin and make a chronic fistula or recurrent infections, and we may see a discharge. This is a case of mycobacterial lymphadenitis. Now, we come to the other areas, which is the vascular areas of the neck. As we know, there is an important space which we say this is the carotid space or the carotid sheath, in which we have the carotid artery, internal jugular vein, the vagus nerve, the sympathetic plexus, and the lymph nodes within this sheath area. And this sheath, as we said before, it's made from all the cervical facial layers of the neck. So any infection or inflammatory process that's involving any cervical plane, it may be extending into the carotid sheath, and it may lead to the pathological conditions. An important entity, which is a carotidemia. Actually, this is an idiopathic condition. Usually it's occurring in middle-aged, mostly females, and they present with a neck pain, and there may be a swelling, point tenderness at the site of the bifurcation of the common carotid artery, in which there will be thickening of the carotid wall, the vessel wall, and there will be involvement of the pericarotid layers by the edema or by stranding or inflammatory changes. Usually I have read that it says it may be intermittent, it may return to normal. So it's an idiopathic condition, and this is a case in which the left side, it shows the involvement of the carotid, and the pericarotid edema and the stranding which is maybe not very clear in this on the screen. And comparing but to the right side, we can see this is a normal carotid, and the other one there is a space.
Here?
Yes.
Oh, it's missing.
Yes. This is known as carotidemia. Another CT scan of the neck with a contrast revealing diffuse soft tissue wall thickening and enhancement surrounding the common carotid artery and the carotid bulb, and extension along the cervical portion of the right internal carotid artery. This is another case of the carotidemia. This is again another case of carotidemia, which is a syndrome, unilateral tenderness, as we said, and near the bifurcation. And it says that it may be associated with a migraine. The patient may have a history of migraine usually, and it's a self-correcting or self-limiting condition. Another condition is the Lemire syndrome. What's the Lemire syndrome? Actually, when we talk about the vessels of the neck, we also have veins, not only the arteries. And the most important one is the internal jugular vein, as we know, and it's extending from the base of the skull, from the sinuses of the skull, and it's extending downwards. So any conditions that may be inflammatory process in the neck or in the region may lead to the venous sinus thrombosis or internal jugular vein thrombosis. Sometimes the internal jugular vein thrombosis, when it's associated with other findings, for example, as we say, the peritonsillar abscess or pharyngeal abscess, this may lead to a syndrome. When we have a peritonsillar abscess or a pharyngeal abscess and it extends to the veins, it may lead to the thrombosis of the veins. And this venous thrombosis may extend downwards. Sometimes it may lead to the pulmonary thrombosis of the apical segments of the lung, in which in this case we call it a Lemire syndrome. This is a 15-year-old girl with an axial contrast enhanced CT image shows a left peritonsillar edema consistent with the tonsillitis. The patient had tonsillitis, and it shows a clot in the internal jugular vein in the next image. And another axial image shows a nodular opacity in the left lung apex, which is consistent with a septic pulmonary embolism. And this is all together, when we find these findings all together, we can call it a Lemire syndrome.
So Lemire syndrome is all three together?
Yes, it's...
and we must have tonsillar abscess, internal
either
jugular vein,
tonsillar or pharyngeal abscess. We have an
inflammatory
infectious
condition,
area
infectious,
and extending to the vein, causing thrombosis with lung involvement. This is all together called a Lemire syndrome. Now, another part of the examination in the CT scan of the neck is the bony air spaces. As we know, we have the nasal sinuses, paranasal air sinuses, and which communicate with the nasal cavity. We have the mastoid air cell, which is important in cases of the middle ear infections and otitis media and otitis externa in the children when it extends. It may be involving the mastoid air cells, and we can identify the mastoid air cell involvement by the loss of the air septa between the mastoid air cells, and usually we can compare both sides so we can identify the abnormality. And sometimes the mastoid air cells, they will be all involved, and they may reach to the petrous apex air cells, and this is known as the petrous apex air cells. Sinusitis either may be acute or chronic, and acute we may have a bacterial sinusitis which makes a fluid level and mucosal thickening, air fluid level or bubbly appearance. This is a finding which we see it mostly in the CT department. We see the bubbly appearance in the sinuses, mostly going with the acute bacterial sinusitis. Sometimes when we have many cases in the CT department, we see it, we say this is sinusitis. But when we see the patient has no symptoms at the current time. It means that this may be previous finding, because the sinusitis findings, they persist up to 8 weeks. So whenever we find these features, the thickening or fluid level or signs of the acute sinusitis, it may not be the condition at the present time. The patient may have recovered from the sinusitis, but the findings will persist up to 8 weeks or more. So we have to take history, and we have to see the patient whenever we see cases of the sinusitis findings. The complications of the sinuses, as we said, it may extend to the other areas, may extend to the orbit, may extend to the skin, may cause cellulitis or intracranial extension, or sometimes cavernous sinus thrombosis or any other complications. The fungal sinusitis is important, sometimes may be life-threatening, because usually it's involving multiple sinuses. It's an extensive involvement, and it's sometimes completely opacifying the sinuses. So the fungal sinusitis, sometimes it's either allergic or invasive. The invasive type is extensive opacification of multiple sinuses, which shows expanded sinus, hyperattenuating material, and extension to the periantral fat stranding. This is a classical sign. When we see the extension to the periantral fat, this is a classical sign of the fungal sinusitis rather than the other causes of the sinusitis. Actually, the fungal is more common in the immunocompromised patients, in diabetic patients. This is another case of the sinusitis in the patient with the diabetes. An axial contrast CT image shows air fluid level and in the left maxillary sinus, consistent with the sinusitis. And the classical periantral fat stranding is seen on the left side as compared to the right side. So, however, it's not an extensive involvement of all sinuses, but whenever we have this fat stranding in the periantral fat stranding, so it's life-threatening. We have to take care of it because it's in a type of the invasive fungal sinusitis which occurs in immunocompromised patients, and it needs urgent management. Another condition, we have acute automastoiditis. It's more common, as we said, in children, middle ear otitis with mastoid air cells, but there is no bony destruction on the CT scan, and there will be fluid in the mastoid air cells with a tenderness on the clinical settings. In the Coalescent Mastoiditis, we have a mastoiditis with the bone erosion. Because we said in acute automastoiditis in children, we don't have bone erosion. But in Coalescent Mastoiditis, whenever we see erosion, we call it's a coalescent. And we said we compare both sides in order to see this destruction, and we can identify the change that has happened between the two sides. The Gardenigo Syndrome is a triad in which we have a facial pain, otorrhea, otalgia, and this facial pain, there is cranial nerve involvement in the Meckel's cave. There is ophthalmoplegia, abducens nerve in Doral's canal, and we have otalgia and otorrhea, automastoiditis. So this is a triad. Whenever we have this triad, we call it a Gardenigo syndrome. Actually, for the nerve assessment and the intracranial assessment, it's better to use MRI, but we can have findings that may go with the diagnosis of this syndrome. This is another CT axial image, shows erosion and widening of the left petrous apex and part of the left clavus. And the CT axial image shows soft tissue density noted within the left middle ear cavity and the mastoid cavity, suggestive of the automastoiditis. This is a case of the automastoiditis. This is another image, CT axial post-contrast study. This one, yes, shows the soft tissue density enhancing collection in the left petrosal apex and the mastoid and the middle ear with the extraaxial biconvex enhancing epidural abscesses. So it has extended into the intracranially to cause epidural abscess. And in the left temporal region, left prepontine cisternae extending to the left CP angle cisternae. And this is the conjunctive MRI axial T2 weighted image. It shows a left automastoiditis with iso to hyperintense collection in the petrous part of the temporal bone, and left prepontine cisternae and the middle ear. So we can assess better by the MRI the internal intracranial regions and the associations. This is another condition which is known as a Bizold abscess, when we have the coalescent mastoiditis with the extracranial abscesses. This is a CT image, shows a tympanomastoid opacification, and there is coalescence of the right mastoid air cells with a breakthrough overlying cortex. There's a bone erosion and the cortex has been eroded, and it's obtained in the soft tissue window, shows overlying or developing abscess, and this is known as a Bizold's abscess. This one is a petrous apicitis. This is the petrous bone. There's a petrous apicitis in 11-year-old girl, presents with the ear drainage and diplopia. The CT image shows a left tympanomastoid opacification, as well as opacification and coalescence of the air cells of the petrous apex. And there is also bone dehiscence, as we see, there is destruction of the bone. And obtained in the soft tissue, we can see epidural phlegmon formation, abscess formation, and non-enhanced foci consistent with the abscess. So there is involvement, intracranial involvement, and epidural abscess formation in association with the petrous apicitis. Another entity which is important to look in the case of the CT of the neck is the intracranial aneurysms. As we know, the circle of Willis, a part of circle of Willis, can be assessed in our CT examinations of the neck with contrast. And it's important to identify an intracranial aneurysm because of its devastating outcome and its consequences. And 3.2% of the population who don't have any symptoms we can find incidental finding of intracranial aneurysm. And intracranial aneurysm is also called the cerebral aneurysms. They are aneurysm of the intracranial arteries. The most common type is the saccular aneurysm. In this case, the case was presented to the emergency department with a slurred speech and mild right arm weakness. As we did this imaging, we find that there is an aneurysm at the end of the basilar artery in the circle of Willis. This aneurysm. This is maybe the cause for the findings which the patient has presented to the emergency department. Actually, in the other image also we can see the hypoxic areas in the frontal lobes, these areas, due to the effect of the aneurysm. In the left frontal lobes we can see it. Another entity to look at in the neck CT scan is the cervical spine. We have to look at the cervical spine as a routine examination of the neck. We can use the neck CT with a soft tissue protocol, but actually the MRI is superior to the CT scan to diagnose the discitis or osteomyelitis. In case of discitis or osteomyelitis, either it's by the hematogenous spread or direct spread from the paraspinal or retropharyngeal or inoculation by instrumentation. And in the CT, we find it as a decreased height of the disc. Actually, we find findings as if it is a degenerative change. But what makes the difference between the degenerative change and the discitis is that we can see the peripheral inflammatory change and the fat stranding or inflammatory change around the disc, which makes it more in favor with the discitis rather than a degenerative change of the disc. So we see a decreased height of the disc, erosion of the adjacent vertebral end plates, associated inflammatory change, obscuration of the paraspinal fat planes, and paraspinal abscess or retropharyngeal findings. If the abscess or inflammatory changes are absent, so it's chronic change. It's not inflammatory or acute condition. In case of the CT scan of the neck, it's good to use a narrow window setting in order to identify these findings in the cervical discs. This is a diagram. We can see that the size for the epidural abscess formations, either we have the anterior spinal epidural abscess or we have a posterior spinal epidural abscess. These are the common sites for the abscess formation. The epidural abscess, they are collection of the pus in the epidural space, and they are most commonly due to sinus infections. When we have a sinus infections, may lead to the epidural infections. In the case of the CT scan, we see a rim enhancing collection with characteristic of epidural collection. It's a lentiform and usually not crossing the sutures. When these abscesses, they result from a temporal bone infection such as a mastoiditis, a rim enhancing epidural collection may be seen between the mastoid bone and the cerebellum or the temporal bone. Now this is a case of the epidural abscess formation. Actually, it's better to see it with the MRI. That's why I have put the MRI image, but in the next image I have put the CT. But the CT findings is increased epidural soft tissue. May be difficult to distinguish it from the disc in the ventral epidural space. In the contrast enhanced CT, there is enhancing epidural mass or collection, and there will be narrowing of the spinal canal. Actually, this is a CT image. We can see it in the upper region. Yes, this is an case of the epidural abscess. And this table shows the risk factors for the epidural abscess formation. The most cases who are in risk of getting the epidural abscess. It's a challenging diagnosis because it's not very easy to find it with the CT scans. It's better to do an MRI. But the epidural phlegmon, this is a case of epidural abscess in the 59-year-old man with a human immunodeficiency virus infection and intravenous drug use. This shows a prevertebral edema. There's a prevertebral edema, and there's also thin enhancing material in the anterior epidural space, which is extending from the C1 to C5 level. This is consistent with the epidural abscess formation. Also, we have to include the orbits in case of the assessment of the emergency CT scan of the neck, because as we said, the level of examination is from the infraorbital region up to the arch of the aorta, the CT of the neck, and the superior orbital vein thrombosis is an important site to look for. And if we see an enlarged vein, we can see a filling defect inside it, and we can see associated cellulitis or abscess formation. And the cavernous sinus bulging outline rather than smooth, and filling defect is seen in the cavernous sinus. We can see the destruction of the bones. We can see the extension intracranially. Actually, all the findings we can see it in this region when there is involvement. For example, when there is involvement of the neck, there may be involvement of intracranial. When there is involvement of the orbital region, involvement again, extension to the adjacent areas. So it's the same findings and the same extensions we have to look for intracranially and in the surrounding regions. Actually, MRI is not recommended if we suspect a fungal infection because it's an emergency condition, and we have to directly go to the management, because MRI, as we say, it's time consuming and it takes more time. And in the epidural abscess, we talked about that. This is a case of the cavernous sinus thrombosis. As we see here, in a 14-year-old girl, we have an incomplete enhancement of the left cavernous sinus, and through which the enhancing internal carotid artery is coursing. The left superior ophthalmic vein, we can see it is dilated and it's not enhanced, and there is associated subcutaneous edema of the face and the edema of the left orbit. And this is another case of the epidural abscess and the subgaleal abscess in a 13-year-old boy. The CT shows opacification of the frontal sinuses and rim enhancing epidural fluid collection, and just superior to the frontal sinus, consistent with an abscess. And also there is subgaleal soft tissue, which is consistent with the subgaleal abscess formation. This is another case of left frontal sinusitis with a left frontal lobe abscess, in which the image shows opacified left frontal sinus and the thinning of the posterior wall of the sinus. And the non-enhanced CT image, just superior to this level, it shows an abscess with a low attenuation center. And there is also another abscess, with a thicker abscess rim, and surrounding edema, of course. And this is a typical thinning of the abscess capsule, is present on the side facing the ventricle. There is a thinning of the abscess capsule. And these findings are confirmed with the MRI actually. And the culture revealed that there is a Streptococcus infection as a causative organism. Another area in which to look is the lung apices and the superior mediastinum. These are the final regions which we look at when we do a CT scan of the neck in emergency setting. It's important because, as we know, when there is a descending mediastinitis or descending infection into the mediastinum, it's vital to diagnose this condition. This is a case of descending mediastinitis in which the patient had a dental procedure prior to this condition, and it shows a foci of the gas and fluid, as we see, in the left submandibular space, with extension into the danger space. As we said, we have a danger space that is extending up to the diaphragm, and a contrast enhanced CT image obtained inferior, it shows an extension to the mediastinum, and left also associated with a pleural effusion, on the left side a pleural effusion, and the trachea and the esophagus are also seen in this region. So this is a case of descending mediastinitis due to a dental procedure that had led to the infection and inflammation of the submandibular region. So overall, lastly, we talked about 12 regions of assessment. It's important to assess each site, and we report each site under its entity. For example, this is a mediastinum, we write our findings, and apices we write our findings. And finally, when we have our findings, we collect them and we synthesize a final impression of our CT report. For example, as we said, some additional findings may lead to a syndrome, and we can have an impression of a final syndrome or final condition. And this is important. The CT findings of a neck should be interpreted systematically, as we said, in the 12 areas, and the findings can be synthesized into an impression that describes the source and the relationship of the disease in the individual areas. And this enables a proper and organized CT assessment of the neck in emergency setting. And thank you very much.
Thank you. So, first of all, very nice, very important, very relevant. Any questions, comments? Good job. Thank you very much. It was very nice work.